Okay, so we're now going to start to talk about some complications of chronic liver disease and cirrhosis, and I'm going to discuss some aspects related to hepatic encephalopathy. So basically, HE is a specific, very specific neuropsychiatric syndrome, and it's found in patients with acute liver failure and in patients with cirrhosis, and they're very different. Those in acute liver failure get brain swelling and can get anoxic brain injury as a result of that, and brain death before they can get a liver transplantation emergently. And those with cirrhosis, it's more of a chronic problem, not associated with increased cerebral pressure. Both of these are associated with mental status changes, psychomotor abnormalities. We measure ammonia, but there are many other things that toxins that contribute to this, and it clearly reduces survival. So this is data looking at the impact of a first episode of hepatic encephalopathy on survival. Overall, once you have your first episode of hepatic encephalopathy, your one-year survival is immediately reduced to 42%, which is much higher than we kind of think about when we see the average patient with hepatic encephalopathy that gets confusion. You say, oh, it's only a little confusion. We'll just put you on lactulose. But it's important to realize the downstream effect of that. That episode of HE is triggering, is a result of chronic progressive liver disease, which is going to continue. And the 3-year survival in this patient is only down to 23%. So these patients, once they present with HE, need to be aware of other complications that are going to potentially occur in the next 1 to 2 years, which is going to significantly reduce their survival. The grade of hepatic encephalopathy also affects survival, the lowest survival being in grades 3 and 4, as you can see there in the right-hand panel. Okay. So although we measure ammonia, there are many neurotoxins that are associated with the syndrome and have been looked at in individual studies, and all of these can be shown to have an effect. Manganese, glutamine, particularly CSF glutamine. Years ago, that was a fad to measure. GABA, benzodiazepines, resines, taurine, and these other agents. So we frequently measure serum ammonia, and the problem that I see a lot of times in the hospital by the hospitalists is that they frequently overreact to serum ammonia. The serum ammonia goes up, they start increasing the lactulose. So it's important to understand that serum ammonia can be elevated in healthy patients. All right, you go out and you have a big turkey sandwich and we measure your serum ammonia 1 hour later, it's going to be elevated. And sometimes you see people that have some type of acute visit to the ER right after they've eaten a high-protein meal. They get measured, their serum ammonia may be 45 or 50, which is elevated, and all of a sudden they're labeled with having cirrhosis, and they don't. The second thing about ammonia is it doesn't correlate with the stage of HE. You can have very mild HE and have an ammonia of 100, or you can be totally comatose with an ammonia of 100. Chronic elevations may not cause symptoms. So people with cirrhosis eventually get used to their elevated ammonia, and they can be perfectly lucid with ammonias in the 70s and 80s, even in the hundreds. And they don't need more lactulose, they don't need more treatment, because what you're treating is not the ammonia, you're treating the syndrome of HE. And you have to keep that in mind because these medicines are way overused because we measure ammonia too often. So you want to use ammonia as a guide. If a patient comes in with altered mental status and their ammonia is normal, they probably don't have HE even though they have cirrhosis. If they come in and they're confused and you lower the ammonia with treatment, but they don't wake up, they've got something else going on and you need to look for that. So where does ammonia come from? It comes from intestinal bacteria. Protein in the gut is broken down into ammonia by bacteria, and in a healthy individual, this goes to the liver and is then converted to urea and glutamine. Amino acids that we eat in our protein, in our food, is also goes directly through that same conversion process. But over 50% of all the ammonia in the body is produced by, or that's been presented to the liver in the portal circulation, is from intestinal bacteria. Now, what happens to that ammonia when you have cirrhosis? There's a decline in ammonia metabolism from the liver, and this occurs from several things. Number one, scarring of cirrhosis and decreased metabolism. But more importantly, a cirrhotic liver has shunting. Blood shunts through it. It's not effectively broken down. And you can have spontaneous shunts that bypass portal blood flow around the liver. And finally, you can induce hepatic encephalopathy in your patients by treating their variceal bleeding or their ascites with the tips. And blood is again shunting through the liver and not being broken down. The standard Yale criteria for classification of hepatic encephalopathy was 1, 2, 3, 4, as shown there, with stage 0 being really no abnormality. And so if there was no abnormality, how do you know that they had hepatic encephalopathy? But stage 1 being very mild cognitive effects, a little giddy, a little euphoric, a little anxiety. Sounds like my oldest son. And as you get worse, they become disoriented to time, inappropriate behavior, acting out. They start to become lethargic. Stage 3, more lethargic, grossly confused, and 4, they can't wake up. Nowadays, we like to simplify this, and basically one classification is simply call it covert HE or overt HE, as I've shown you there. And covert HE meaning it's very subtle, it's hard to detect, and there may be these very subtle signs with elevation in ammonia or other psychometric testing abnormalities that I'll show you in a minute, whereas overt is really obvious. Another classification recently proposed by the HE study group was A, B, and C. A for acute liver failure. That's when your liver, you're going through acute liver failure, and you can get cerebral edema. Another classification, the B would be portosystemic shunting through spontaneous shunts, and C would be cirrhosis. The grade is either, again, covert or overt, minimal or 1 versus 2, 3, or 4. They like to see the time course. Is this episodic? Is this occurring in more than 6-month interval time frames between intervals? Or is this recurrent HE, where it's occurring more frequently in less than 6 months? These are your patients where you discharge them, they can't afford their Xifaxan, and they're readmitted to the hospital with HE every week. And then what's the precipitating factor? Is it an infection? Or is it noncompliance with medications? Protein overload is actually less of a common issue than we attribute it to. So how do you identify these people with these very, very subtle changes neurocognitively and this covert hepatic encephalopathy? And one of the biggest ways you can do this is with the Stroop test. Now, the Stroop test is actually an old test. It was developed in 1935 by John Stroop, and it is basically was developed. John Stroop was a psychologist or a psychiatrist, and he developed this to assess reaction times of a task for focusing and attention. And when you have mild covert encephalopathy, that's one of the problems. You can't process as quick as you normally do. So it's like a ADD or an inability to process very quickly. So, and basically, the test is very simple, and it looks at when you give the name of a color is printed in the color that's not denoted by the word, it takes longer for you to recognize that. For example, I've given you two things here. So the test can either print red, blue, green, where green is in green, or it can give you red, blue, green, where green is not in green, and you have to recognize the difference between that. And the second one is much more difficult, and you make errors. And that's what the Stroop test assesses, your error rate. It was applied to hepatic encephalopathy in 2000 by Dr. Bajaj, who's also in Richmond, one of my former partners, who's really revolutionized the field of HE. He was a pretty dead, comatose field, stage 4 HE, for many, many years before he started working in this. And now a lot of people are working in this field. And basically, he created the Encefal app, which you can download. I have on my cell phone. And basically, it uses the same principle, and it basically gives you a bunch of hashtags that is in a certain color, and then you have to touch the right name of the color. And the name of the color moves around, and so you have to find the right name. And it gives you a score. Now, why is it important to identify covert or at least suspect covert hepatic encephalopathy in your patients? Because it potentially causes them harm. These patients, they look good, they're out there driving, and these patients are bad drivers. They're almost as bad drivers as my family tells me I am. If you look here in this study of controls, no covert hepatic encephalopathy or covert encephalopathy, you can see that the overall driving error rate is significantly higher in those with covert encephalopathy. They handle the car more poorly. They adapt to dangers in the road, somebody stepping out more commonly, and their maneuvering ability is abnormal. So when you talk to your patients and you ask them, how are you doing, any problems with confusion, they say, no, I'm doing fine. And then you ask them, well, when you drive, do you turn on the wrong streets? Do you obviously you're driving home, you know you have to stop at the drugstore and pick something up, and the next thing you know, you're in your driveway and you wonder, was I supposed to stop at the drugstore or not? That's covert encephalopathy. If you look at motor vehicle accidents, because reaction time of these patients with covert hepatic encephalopathy is a slight slower, these patients have more motor vehicle accidents. If you look at controls, healthy controls, and you look at the cirrhotics there, and you look at those with minimal or covert hepatic encephalopathy, significantly higher rate, almost doubling the rate of motor vehicle accidents in 1 in 5 years. So if you have cirrhosis and minimal or covert HE, a third of those patients will get into a significant motor vehicle accident within 5 years, and 17% in 1 year. Whereas if those patients, if you just look at patients with psychiatric disease, they have the same motor vehicle accident rate as controls. Now, if a patient with cirrhosis now, because they had covert hepatic encephalopathy, got into a motor vehicle accident, because they have cirrhosis, they have a much higher risk of bodily injury and in-hospital mortality. So they get in a car accident, they're brought to the hospital, they're given fluids, they have cirrhosis, they get fluid overloaded, then they get infected, and it just spirals the whole thing out of control, and that increases their mortality. So you can see patients there with cirrhosis that have motor vehicle accidents compared to patients who have motor vehicle accidents without cirrhosis, or patients with cirrhosis that didn't have an accident. You can see in-hospital mortality of those patients with cirrhosis that had motor vehicle accidents is significantly greater. Covert hepatic encephalopathy also affects the patient's sleep. And this is one thing that may tell you. They say, I can't sleep, I can't sleep. You need to give me something for sleep, as Catherine just told you. Okay? If you look at this study of controls in patients with cirrhosis, their sleep time is less than 6 hours is significantly higher. The amount of time it takes them to go to sleep, significantly higher. The amount of times they wake up in the middle of their sleep, much more common, 2.7 versus less than 1. And the number of naps they take during the day is more than 4 times, almost 5 times higher, 7 versus 34. So these patients with covert hepatic encephalopathy and ascites, they have a lot of problems with sleep. And the reason they take so many naps during the day is because they don't sleep at night, and it becomes a vicious cycle. They can't sleep at night because they have naps during the day. One of the things that contributes to this is secretion of melatonin. Melatonin secretion is significantly shifted to appear or to come out later in the middle of the night, and so that accounts for this sleep latency, this inability to fall asleep after being in bed for a while. If you can see in the controls, the normal peak of melatonin is right around midnight, whereas in patients with cirrhosis, that peak of melatonin production is more towards 4 in the morning. So they're up all night, and then they finally fall asleep when it's time to wake up. So what do? Well, as Catherine mentioned, you tend to give them a whole kinds of different medications for sleep, including things that can now convert them from covert encephalopathy to overt encephalopathy. So the medications that are commonly prescribed are opiates. Why? Oh, I can't fall asleep because my back hurts. I have chronic back pain. So we're going to give them more of an opiate, and now they have that problem. Or you give them benzodiazepines, which precipitates more HE. Psychoactive medications like trazodone or others, and anticholinergic medicines, all of which can lead to worsening HE. So, as Catherine said, the better choices for sleep are melatonin, and that's the first thing I try. I tell them to go to GNC and get some melatonin and see if that works. I tell them, stay up during the day, do not nap during the day. Put a buzzer on every 10 minutes, have it ring loudly so it wakes you up if you fell asleep. Get out, do things, do not fall asleep during the day. If they have a partner there during the day with them, they can wake them up as soon as they fall asleep. But they've got to break that cycle of sleeping during the day if they're going to sleep at night. You can use Tylenol if they have pain. As Catherine mentioned, as long as they're not active alcoholics, Tylenol is a perfectly safe medication for pain, probably much safer than NSAIDs. If they have sleep apnea in this era of obesity and NAFLD as a cause of cirrhosis, many of our patients now have sleep apnea. Let's make sure that's evaluated and treated. And the best drug to use would be antihistamines. And this is a study showing subjective improvement in sleep, 40% versus 0 for placebo when antihistamines are given. And objective improvement was 2/3 versus 1/4. Now, when you have ammonia, we've already said that the most important place that ammonia is broken down is in the liver. But the second most important place ammonia is broken down is in the muscles. And Catherine did a great job showing the importance now we understand of sarcopenia and contributing to a whole host of problems with cirrhosis, increased mortality, increased post-transplant mortality. So when you have cirrhosis, if you have poor muscle mass, you don't have a secondary backup for your ammonia, because your muscles are not there to break it down. So if you think about your patients with bad HE, they're all wasted. They're all frail. They all have poor muscle mass. Your patients that are still strong and still have good muscle mass and didn't decompensate their muscles, they don't have a problem with hepatic encephalopathy. Most of them don't have it at all. And they're good TIPS candidates as a result of that, and they won't get HE after TIPS. There are many factors in patients with cirrhosis that cause muscle wasting. You get portal hypertension, shunting of blood, ineffective hepatic caloric utilization leads to muscle wasting. You have ascites, so they can't eat. This is why it's so important to aggressively treat refractory ascites and make it go away. I don't want any of my patients having refractory ascites. We need to make it go away, not just to reduce the risk of SBP, because they can't eat. And so these patients that come to me and they've had paracentesis every 2 weeks for 4 months, that's ludicrous, because during that time they probably lost about 20 pounds of muscle mass. And now they're very frail, and now they're no longer a good TIPS candidate, because they're going to get worse HE when you put a shunt in. So what happens in these people that get poor muscle mass is they've got cirrhosis on the one side, they've got puny little muscles on the other side, and now they've got nothing to break down their ammonia, other waste products, and everything goes to the brain, and they have refractory HE, and it's a problem. So treatment, how do we treat HE? Well, the mainstay is lactulose. It was actually studied in only a few patients. It's probably like aspirin. It's like one of those medicines that would never make it if it went in front of the FDA today. Okay? These studies you see were in the 80s. The important thing about lactulose is don't treat the ammonia level. Treat the patient with HE. Treat the symptoms of HE. I don't care what the ammonia level is. If the patient is not confused and you don't think he has covert HE, he doesn't need lactulose, or he doesn't need more lactulose. The typical dose is 2 to 3 times a day. Patients cannot tolerate more than 3 times a day. Patients that are taking lactulose chronically 4 or 5 times a day, they can't tolerate that. They're going to have massive diarrhea, have electrolyte problems, and that's going to make encephalopathy worse. Now, it's different than when a patient comes in acutely encephalopathic in the hospital and you give them lactulose to wake them up. That's fine, but then you immediately need to back down to only 2 to 3 times a day. Secondary prophylaxis, once a patient has an episode of HE, the addition of lactulose plus rifaximin or Xifaxan has been shown to be much more effective than simply continuing lactulose alone. This was the study published in New England Journal of Medicine by Nathan Bass, and it shows free of encephalopathy significantly improved. If you don't use Xifaxan, 40% of your patients are going to get a recurrence of HE and be rehospitalized within 6 months, whereas if you add Xifaxan to lactulose, only 20% of your patients will be readmitted. And so hospitalizations are significantly reduced with the combination compared to lactulose alone. Minimal hepatic encephalopathy can also be impacted and helped by lactulose. And here, if you look at using low-dose lactulose in somebody that you suspect has covert or minimal hepatic encephalopathy, if you don't give any treatment, if you don't have any covert encephalopathy, the rate of getting an episode in 3 months is less than 10%. If you use no lactulose, it's much higher, and you see lactulose is going to significantly reduce that. So what are the precipitating factors that lead people to get HE? We all say, oh, they've been eating too much protein, but actually dietary protein is a very small cause of HE in these patients, only about 5%. The single 2 biggest things are azotemia, dehydration, and use of sedatives or analgesics, opioids and benzodiazepines. So you want to avoid those. There are some patients that even with lactulose and Xifaxan, they still have some confusion. And as Catherine said, we want to adequately give protein to our patients with cirrhosis, but there are some patients that just can't handle as much protein as they should. But you don't want to arbitrarily just restrict protein because you don't know how much they can tolerate, and if we restrict protein, it's going to potentially reduce their muscle wasting. So what do? What I do is I develop the protein diary, and I have patients track every protein item they eat every day and count them up. And then when they have an episode of HE, then I know they've had too much because it's usually an increase in the amount of protein. So this is my protein diary from back in July, and I had an egg for breakfast, chicken for dinner, and I had some peanuts for a snack, so I had 3 protein items. And then the next day I had a turkey sandwich and 2 meatballs, also 3 protein items. And then an egg with bacon, that's 2 protein items, peanut butter sandwich and some fish, that's 4. And I did okay until the 15th when I had 6 protein items. I had 2 eggs, a sausage, that was good, a hamburger with cheese, that's 2 protein items, and a chicken for a total of 6 protein items. And guess what? The next day I was confused. That's your target. Now you know the target on that patient. As long as you stay below 6 protein items a day, that patient's going to do better on their lactulose Xifaxan therapy. And you use this to restrict protein to the minimalist degree, making sure they get as much protein as they can tolerate without getting overtly confused and having to be rehospitalized. Sometimes the protein diary doesn't work. Sometimes the patient gets confused no matter what you do. And in those patients where you've done everything and it doesn't make sense, why is the patient keep getting HE? They may have a spontaneous shunt. So there are lots of spontaneous shunts that can occur in cirrhosis. And here's my cartoon of liver, stomach, you can see the circle there, that's gastric varices, leading to a spontaneous splenorenal shunt. And if a patient with refractory HE has a shunt, it can be a spontaneous splenorenal shunt, it can be an umbilical vein shunt, and if you have your IR person go in and occlude that shunt, then there's no more shunting, the blood is forced through the liver, and it's going to metabolize the ammonia much better. And that does work on many occasions if they have the shunt. So in summary, try to recognize covert HE, counsel patients with that about the danger of driving. There are actually a few states that actually say that you have to report people with encephalopathy to DMV. Most states do not. You probably ought to look at that from whatever state you're in. Address insomnia and poor sleep. Eliminate medications which can contribute to HE. Treat HE to prevent additional episodes. And then for those that are really refractory, define the protein limit they can take, they can tolerate, or look for shunts which you can embolize. Thanks very much.